Welcome to Raaonline. Today we have a very interesting topic, Listeria Monocytogenes. Whenever you handle patients on meningitis, or if your exam topic comes to be as meningitis, definitely they will be discussing about Listeria meningitis also. Okay. Moreover, whenever you speak about Listeria, there is one more bacteria called as Legionella. Okay, don't get confused with Listeria and Legionella. Okay, we have a different seminar on Legionella as well. Okay, so once you complete your Listeria monocytogen seminar here, have a look at the Legionella seminar as well, just to compare. Okay, Listeria affects a different set of systems in your body, where Legionella affects a different set of systems in your body. Okay, so we'll start with Listeria monocytogenes. Okay, so the picture which you are seeing here, this is not Listeria. Okay, this is just for seminar sake. Okay. So, Listeria monocytogenes is a foodborne pathogen, okay, that can cause serious infections, particularly in immunocompromised and pregnant women. Okay. It is ubiquitous, meaning it's almost present everywhere, and saprophyte. Okay. It eats on dead materials basically, and it's an environmental bacterium with a broad host range. Actually, humans are probably accidental host for this microorganisms. Okay. So, Listeria monocytogenes is a facultative anaerobic, non-spirulating, gram-positive rod. Okay, every word is very important, dear friends. Okay, that grows over a broad temperature range, including refrigerated temperatures as well. Okay, so whenever we speak about a bug, imagine that to be our enemy. Okay, so we need to know what are the weapons of the enemy, how the enemy can survive, and how it's getting into it. So only when you know the strength and weakness of your enemy, you'll be able to develop an antibiotic against it, right? So whenever you speak about a bug, okay, understand the environmental conditions it can survive also. So this grows over broad temperature range, including in your refrigerated temperatures. Okay, actually to say, motile growth is present at low temperatures. Okay, so if you refrigerate certain foods, the Listeria can grow very fast. Okay, but that such kind of motility is actually comparatively less at room temperature. Okay, so refrigeration worsens the disease, worsens the quantity of Listeria present in that particular food substance. Okay, particularly to say, human Listerial disease is caused by serotypes 1 by 2A, 1, 2B and 4. Okay, moreover, Listeria monocytogenes is weakly beta hemolytic on blood agar. Okay, and specifically mention things here because this is a MCQ. Okay, the beta hemolysin is a very, very essential determinant of the pathogenicity itself. We'll see on it detail. Okay, so as of now, you know that Listeria monocytogenes is a ubiquitous, it's a saprophytic, non-spirulating, facultative, anaerobic, gram-positive rod. Okay, it grows almost in a wide range of environmental condition, and humans are an accidental host maybe, and it can multiply. It is more motile at low temperatures, but gradually the motility is less comparatively at room temperatures. Okay, so this is what Listeria looks like. Okay, whatever you see here is gram-positive, right? So pathogenesis, if you see, it starts with ingesting the contaminated food containing the bacteria at very, very high concentrations. Okay, so once this saprophyte organism is consumed along with the food, the conversion from the environmental saprophyte to a human pathogen involves three different abilities of this bacteria. One is entry into the cell, second, intracellular growth, third is cell-to-cell spread. Okay, only when these three capabilities are present for the bacteria, it will infect and produce an infection in the human host. Okay, so for each and everything of this particular capability, there are some bacterial determinants. Okay, bacterial genes present in it, bacterial abilities present in it. Okay, so to activate all these things, you need a central trigger. Okay, that central trigger is a transcriptional activator called as PRFA. So when this saprophytic pathogen is actually taken along with the food substance by the humans, the first activator, the transcriptional activator gets activated, it's PRFA. So once the PRFA of the bacterium is activated, this activates majority of other genes which is required for entry into the cell, intracellular growth and cell-to-cell spread. Okay, so like any other enteric pathogen, so imagine this is the gut, imagine this is the gut. Okay, and your intestines follows here. Okay, like any other enteric pathogen, the Listeria monocytogenes induces its own internalization by cells that are not normally phagocytic. Okay, I am speaking about the normal mucosal cells, speaking about the normal epithelial cells of the intestines, right? So once this kind of bacteria is present, okay, it makes its own internalization into the cell so that this particular bacteria enters into the cell and gets into the phagosome, into the normal cells. Okay, so this entry into the cells is mediated by the host surface proteins called as internalins. Okay, so more there is internalins, the more going to be entry of this particular bacteria into the cells. Okay, so this kind of internalins is very, very essential for this bug to cross the intestines, for crossing the blood-brain barrier and even the feto-placental barriers. So internalins is very, very important. Okay, the most important determinant of the pathogenicity of Listeria monocytogenes is the beta hemolysin. It's called as listeriolysin O, otherwise we call as LLO. Okay, so once imagine this is a normal cell, basically an epithelial cell or further deep down the intestinal cells. Okay, if there are internalins, because of the internalins, this particular bacteria is engulfed inside. Okay, engulfed inside. So once it is getting engulfed, usually it should form a phagosomal membrane, right? Phagosomal membrane, so that this bacteria stays inside, right? But what this listeriolysin does is, the listeriolysin engages itself into the phagosomal layer, and prevents the maturation of that phagosomal layer, right? So once the phagosomal layer is not matured, the phagosomal layer goes for rupture. So once the phagosomal layer ruptures, this particular bacteria comes to the cytoplasm. Okay, so LLO is responsible for rupture of phagosomal membrane. LLO is a pore forming cholesterol dependent cytolysin. Okay, this LLO, basically the listeriolysin O, is actually related to the streptolysin O, pneumolysin, perfringolysin O, all of which are produced by extracellular pathogens. Okay, this is one intracellular pathogen. This LLO probably acts by inserting itself into an acidifying phagosome, thereby preventing the vesicle maturation. Okay, so once they have prevented the maturation of the phagosome ruptures, right? And moreover, there is an inverse relationship between the toxicity and the virulence. Okay, the more toxic the strain, the less virulent it is on animals. Okay, there's a difference between the toxicity and virulent. Okay, so one is it grows very severely into the body systems. The other toxic, cytotoxic, meaning it can cause multiple organ dysfunction. Okay, so virulence is the capacity of the particular bacteria to grow inside a human being. It's called virulent. Okay, but cytotoxic is it can affect many organ dysfunctions. So once the phagosomal layer is ruptured and the bacteria enters the cytoplasm, the Listeria monocytogenes grows very rapidly in the cytoplasm. Okay, so now this particular human being has consumed food possibly with high quantity of Listeria monocytogenes. So once inside the gut, because of internalins, this particular bacteria is taken up into the cell, into the phagosomes, okay, into the phagosomal membranes. So this particular bacteria has a beta hemolysin, okay, which is responsible for immaturation or preventing maturation of the phagolysosome. Okay, so because of that, the phagosome ruptures, this particular bacteria comes out to the cytoplasm and it grows a lot, right? So now, during all this time, what is our immune system doing? Okay, so there were extensive studies done on mice to understand where this particular bacteria from the intestine travels and what is the initial line of defense and what is the external line of defense. Okay, so shortly after IV injection of the bacteria in the mice, okay, they are doing a trial, they are doing a research basically. So shortly after IV injection of the bacteria in the mice, most bacteria are found in the Kupffer cells in the liver and the splenic macrophages. Okay, so Listeria that survive the bactericidal activity of initially infected macrophages grows in the cytosol and spread from cell to cell. Okay, so in the liver, the result is infection of other hepatocytes. Okay, so now this is where it's get traveled along. Okay, so once from the gut, it enters into the blood. After in the blood, it gets concentrated over the liver and the spleen area, right? So in the first 24 hours, it is the neutrophils. Okay, after the 24 hours, it is the macrophages. This is the line of defense. Okay, so neutrophils are crucial to host defense during the first 24 hours of infection, whereas the influx of activated macrophages from the bone marrow is critical after this 24 hours and subsequently. Okay, So mice that survive this kind of sublethal infection, okay, if it's only a minimal amount of infection, they clear the infection within the week with consequent sterile immunity. Okay, what is the meaning of sterile immunity, dear friends? See, immunity meaning, for example, there is a human being and particular bacteria is being inserted into him. Okay, so the bacteria also multiplies, and there is an immunity from the body which fights against this bacteria and it shuts it down. Okay, this is called as a immunity, right? Sterile immunity meaning even before the bacteria can cause an infection, even before the bacteria can develop, can multiply, can extend its territory. If at all the body is able to control it at the entry level itself, that is called as sterile immunity. Okay, so that particular bacteria at the entry itself is being completely controlled. That's called sterile immunity. Okay, most of the bacteria in the stomach is basically controlled with sterile immunity because of the acidic pH. So now you got what I'm trying to say, right? So before it spreads, before it multiplies, before it could cause infection, if all that bacteria is being controlled, that is called a sterile immunity. Okay, not only neutrophils and macrophages, even interferon gamma and tumor necrosis factor are very, very essential in controlling this infection. This is proved by knockout mice. Okay, so mice in which the interferon gamma and tumor necrosis factor are absent or knocked out, they suffer from serious infection. So that means that interferon gamma and tumor necrosis factor are essential in controlling this infection. So we need neutrophils, we need macrophages, and interferon gamma and tumor necrosis factor. Okay, so although this kind of innate immunity is sufficient to control infection per se, acquired immunity response is required for sterile immunity before even the bug develops into the body. Okay, so for sterile immunity, we need some acquired immune response as well, right? That acquired immune response is from cell mediated immunity. There is no role for antibodies here. Okay, for cell mediated immunity, it is actually CD8 plus T cells. Okay, so when there is T cell immunodeficiency, or because of some chemotherapy the T cells have come down, those patients are more prone to develop Listeria monocytosis infection as well. Okay, the critical effector factors are cytotoxic CD8 plus T cells that recognize and lyse infected cells, right? So this is very essential for sterile immunity. So the Listeria monocytosis enters the cell. Once the cell is infected and the body understands the cell has been infected, it's CD8 plus T cells which goes there, lyses the cell, kills the cell then and there itself. There is so no point or there is no time for the particular bug to develop out of the phagosome, to develop in the cytoplasm, to develop cell to cell at all, right? This is called a sterile immunity. For sterile immunity, you need cytotoxic CD8 plus T cells. Okay, the bacteria otherwise, the bacteria grows and spread from cell to cell. The host recognizes and lyses the infected cells, and extracellular bacteria are killed by circulating activated phagocytes. Okay, coming to epidemiology, Listeria monocytogenes usually enters the body via the GI tract in foods. Okay, listeriosis is most often sporadic, although outbreaks do occur. Okay, this is usually sporadic for simple reason, dear friends. For example, you buy a food material from a grocery store. Okay, a packed material from a grocery store, right? So some cook instantly, some will keep it up in the refrigerator for around 2-3 days or even 5 days, and then they start cooking all those things, right? So the time to consume these kind of foods differ from consumer to consumer, right? So because of that reason, the quantity or the amount of listeria present in that particular food substance can be variable from consumer to consumer based upon the time since they bought and time since they're going to consume it. Okay, so for that reason, listeriosis is often sporadic. Okay, annual incidences reported is only 9 per 1 million cases. This is in US. Okay, and most of the listeria are underdiagnosed or even not diagnosed at all. Okay, so this number can be very, very high in underdeveloped or developing countries. Okay, moreover, no epidemiological or clinical evidence supports human to human transmission apart from your vertical transmission from mother to fetus, and there are documented evidences from, if the quantity of listeria is very high, from the fetus to mother also it can go. Okay, or waterborne infections. So moreover, we informed you that when the temperature is very less, that is refrigeration temperature, Listeria monocytogenes can grow better, right? So in line with this survival and multiplication at refrigeration temperature, Listeria monocytogenes is commonly found in processed or unprocessed foods of animal and plant origin, especially soft cheese, meats, hot dogs, milk, cold salads, which is usually refrigerated, packed, processed, and they are kept in the fridge for longer time. Okay, and moreover, nowadays because food supplies are increasingly centralized, a normal host can tolerate the organism well, outbreaks may not be immediately apparent, right? The food substance which you are eating, the packed food substance which you are getting from your local grocery store may not be processed there, right? There's a central unit. It can be very far away also. There's a central unit, and this kind of materials can be passed almost India-wide, almost your country-wide, right? So to trace whether this particular compound is produced from this particular food supply chain is going to be extremely difficult, okay? For that reason, even if there is an outbreak, 5 will be in this area, 5 people will be affected maybe in a different area, and around 10 will be affected in even more a different area. So you won't realize that there is an outbreak at all in the first place, right? So on a first thing, what you need to do is, if at all you found Listeria, and for example, there is more than 4 or 5 members affected in the same family, and you know it's because of the particular contaminated food, to trace the food chain, you need some evidence, right? So pulsed field gel electrophoresis will tell you whether this particular food is responsible for your listeriosis, and whether this particular food is packed from this particular area, whether these two foods are relatable, okay? So this is how the community medicine team can organize a particular chain assessment, and they can catch hold of the particular centralized unit, and they can do a check there. So how are you going to diagnose this? Understand, timely diagnosis requires that the illness is considered at risk group on the first place, right? A fully young immune person, apart from developing some basic GI symptoms, will not have overt infection at all, okay? People who are immunosuppressed, neonates, pregnant woman, elderly person, patient who underwent organ transplant, cancer patient, or treated with TNF antagonist or steroids, okay? So these are the people who are actually suppressed in immunity, and they get infected or more prone to listerial severe infection, okay? And patients with chronic medical condition like alcoholism, diabetes, renal disease, rheumatological illness, or iron overload, all these conditions can decrease your immune system, and thereby the listeria can outgrow your immune system, okay? Also do suspect if an elderly man is coming with meningitis, especially with the parenchymal brain involvement or subcortical brain abscess, or there's a local outbreak of culture negative febrile gastroenteritis, okay? So in these two conditions, you need to think of whether it's Listeria monocytogenes, okay? So elderly gentleman coming with meningitis, you are doing an LP, and LP is not showing any evidence of any bacterial fungal infection with respect to WBCs, with respect to your proteins, with respect to your sugars, then we can claim it as an aseptic meningitis, right? Listeria is one of the topmost causes of aseptic meningitis, okay? And moreover, in a local area, there's an outbreak of febrile gastroenteritis, but culture, the stool culture is negative, okay? Even then you need to consider a Listeria outbreak, okay? So you need to know who are the at-risk people, and you need to know how the usual presentation is. Based on these things, you need to suspect a Listeria, okay? In simple language, if the most common reasons are not fitting into your diagnosis or coming negative in your assessment, then you need to think of uncommon things also, okay? In that scale, you need to think of Listeria as well. Elderly gentleman coming with meningitis, MRI is negative, LP you are doing, and LP is showing completely clear CSF fluids, then you can suspect Listeria. Or in MRI, you see a parenchymal brain involvement or a subcortical brain abscess, then you need to think of Listeria as well. So listeriosis occasionally affects healthy, young, non-pregnant, fully immune individuals as well, okay? I'm not saying you will not get Listeria in normal people, okay? You can get Listeria in normal healthy people as well when the dose of Listeria, when the quantity, the amount of Listeria concentrations were extremely high, okay? Moreover, HIV infected patients are definitely at risk, right? Whenever we think of immunosuppression, immunodeficiency, it's definitely HIV, right? But however, Listeria seems to be prevented by one prophylactic medicine which these AIDS-related people are taking. That is, trimethoprim sulfamethoxazole is given as prophylaxis in HIV treatment, okay? So this trimethoprim sulfamethoxazole will take care of listeriosis. So HIV patient, infected patient who are on this trimethoprim sulfamethoxazole are actually prevented from listeriosis. So now, what is the gold standard diagnosis? The diagnosis is going to be culture of blood and CSF or amniotic fluid, okay? Patients who have only GI symptoms may not have a culture positive blood, okay? Patients who have only GI symptoms need not have severe diseases, Okay, if it's not a bacteremia, if it's not spreading to your liver, if it's not spreading to your brain, then it is less likely to be a serious infection. Okay, you can handle a gastroenteritis the way you handle other dehydration, other hemodynamic parameters, the ABCD approach itself. Okay, so culture negative febrile gastroenteritis, you can think of Listeria and start treating the patient. Okay, but if there's multi-system involvement, definitely there's going to be a blood culture positivity in that. Okay, then Listeria monocytogenes may be confused with diphtheroids or pneumococci in gram stained CSF, or maybe gram variable. It can look like a coccobacilli and can be confused with Haemophilus species as well, right? So you'll be continuing treatment, but there won't be any reasonable improvement in the patient, right? So you need to wait for the cultures and then take a call on it. Or clinically, if the patient comes under the risk category, and if the CSF is not showing any gross evidence, or MRI is supportive of Listeria, then you can straight away start treatment for Listerial meningitis as well. Okay, serological test, PCR are not clinically useful diagnostic at present. Okay, it's the culture. So Listeria infections present as several clinical syndromes, of which the meningitis and septicemia are very, very common. Okay, apart from your GI symptoms, right? So Listeria gastroenteritis typically develop within 48 hours of ingestion of large inoculum of bacteria in contaminated food such as milk, meat and salads. Okay, especially if they are refrigerated. Okay, now think how many of us in our refrigerator have sambar, have food, have fried rice which were cooked around 2 days back or 3 days back, kept in refrigerator for supply later, right, for serving later. Okay, so that is a good source of Listeria basically, right? So never consume all those things. So attack rate is as high as 100%. You take such high concentration, definitely you're going to get affected. Okay, Listeria monocytogenes is not found in routine fecal culture as well. Okay, so there'll be fecal culture negative gastroenteritis, right? And the patient is not improving other management, you can think of Listeria monocytogenes gastritis, right? Hence, its involvement should be considered in outbreaks when cultures for other likely pathogens are negative, right? When the common pathogens are negative, then you need to think of uncommon things, which is Listeria again, right? Manifestations include fever, diarrhea, headache, and other constitutional symptoms. So why we are discussing about this is, just imagine this situation, dear friends, and you will understand the gravity of Listeria. The largest reported outbreak occurred in an Italian school system, which included 1,566 individuals. Just imagine you are in your emergency department in your area, and suddenly you receive around 1,566 school students or college students with acute gastroenteritis. 1,566 people, right? And they are from your same locality, right? It's because of foodborne disease. It's from the same locality, from a school. 1,566 people coming to you with dehydration, coming to you with all sorts of acute gastroenteritis symptoms, right? So it's going to be very deadly, right? Apart from these people can be treated for dehydration, can be treated for acute gastroenteritis. Among them, 20% required hospitalization, roughly around more than 300 people. More than 300 people required hospitalization. Okay, they were admitted. Okay, among them, only one had a positive blood culture. Okay, so most of these things will be contained in the GI tract itself. So if it's a GI tract related issue, you can handle your gastroenteritis alone without any systemic bacteremia manifestations or systemic bacteremia antibiotics. So isolated GI illness does not require actually antibiotics. Okay, and surveillance studies show that 0.1 to 5% of healthy asymptomatic adults may have stool culture positive for this organism. Okay, for that reason, don't rely on fecal cultures to diagnose a Listeria induced gastroenteritis, right? So basically, your differential diagnosis about gastroenteritis should have Listeria, not to start an antibiotic for GI reasons. It is basically to identify there is an outbreak, to check whether that particular food is properly processed or not. It's for the community reasons, right? Apart from the GI tract, if that particular bacteria has managed to enter into the cells and develop into the cells, okay, it has surpassed the neutrophils, it has surpassed the macrophages, it has surpassed the CD8 plus cells, it has surpassed your TNF and interferons, and then it is causing some infection, then there will be some bacteria in the blood. Okay, so bacteremia usually in terms of Listeria monocytogenes septicemia presents with fever, chills, myalgia, arthralgia, and cannot be differentiated for septicemia involving other organisms. Okay. Meningeal symptoms, focal neurological findings, or mental status changes may suggest the diagnosis. A patient coming with acute gastroenteritis and headache along with your meningeal signs, you can think of Listeria. Okay, one bacteria which is related to GI symptoms and the neurological symptoms, but GI culture, the stool culture is negative, and even the CSF can be normal, and it is not giving you any signs of any other infection, any other common infection, then you need to think of Listeria. Okay, so bacteremia has documented about 90% of cancer patients with listeriosis. So when there is the immunodeficiency, bacteremia is going to be very common. So Listeria monocytogenes causes around 10% of all cases of community acquired bacterial meningitis and results in United States as well. Okay. Case fatality rates are reported to be around 26%. Okay, 1% in every 4 is going to die. Okay, this diagnosis should be considered in all older or chronically ill adults with aseptic meningitis. A non-specific flu-like illness with fever is a common presentation in a pregnant woman. Most of the time, these get neglected because thinking it's going to be just a flu, right? So, in pregnant women, they can cause certain complication as well, which we'll discuss a little later. Endocarditis of prosthetic and native valves is an uncommon complication, but still can occur. If occurred, it has a fatality rate of around 50% in case series. Okay. The presentation is more frequently subacute, with illness developing over several days, maybe some 1 or 2 weeks, than in the meningitis of other causes. Okay, and the nuchal rigidity and meningeal signs all will be very, very less. So patient comes to you with acute confusional state, okay, with history of food intake from outside, with history of gastroenteritis. You do an MRI, may be negative. You do a CSF, may be negative. The stool cultures could be negative, and by the history, you know that this presentation is developing subacutely. That's over several days. And the other signs of nuchal rigidity and meningeal signs are also less common. Then you can suspect a Listeria and treat it. Photophobia of infrequent, focal seizures and findings are also uncommon. Okay. In some cases where the immunodeficiency is very severe, then CNS findings will be more pronounced and common. Okay. The CSF profile in Listeria meningitis most often shows a WBC count within the range of 100 to 5000. Okay. Rarely higher. I can tell you around 75% of the time you will see WBC count below 1000 only. Okay, usually lymphocyte predominance, usually neutrophil predominance. Low glucose levels and positive results can on gram staining are found around 40% of the time only. 60% of the time it's going to be maybe negative. So meningoencephalitis and focal CNS infection. Listeria monocytogenes can directly invade the brain parenchyma because of internalins, which we told you, producing either cerebritis or focal abscess. Okay, this is one of the very common reasons of focal abscesses in the brain. Approximately 10% of cases of CNS infection or macroscopic abscesses resulting from bacteremic seeding, bacteremic spread from the positive blood of the patient. Okay, in those patients where you see an abscess in the brain, definitely the blood culture will show the particular bacteria, the Listeria. Okay, because it's more likely a bacterial spread to the brain. So your bacteria culture from the blood will be positive. Concurrent meningitis can exist, but the CSF may be normal in more than 50% of the time. Right? Abscesses can be misdiagnosed as a metastatic or primary tumors, and in rare instances, it can occur in cerebellum and spinal cord as well. Right? A proper treatment, a proper diagnosis is very essential, because if you think as metastatic cancers, if you think as itself as a tumor, then you won't start the patient on antibiotics as well. Right? Then you will miss out the diagnosis. Right? So proper history is very, very required. You need to think whether the patient comes under a risk category. You need to assess how the patient's immune status is and discuss with the radiologist whether it's really a metastatic tumor or it more likely looks like an abscess, right? Because this disease is completely treatable, right? Invasion of the brain stem results in characteristic severe rhombencephalitis, usually in otherwise healthy older adults. The presentation may be biphasic. For example, initially the patient can have fever, headache, then can have this cranial deficit, cerebral signs, hemiparetic, hemisensory deficits, which is more severe. Okay, initially to start with, the patient can have a slow form of disease. Later, it can go very severe as well. Okay, the severity can be very severe that even respiratory failure can occur because of cerebral reasons, because of medullary involvement reasons. The subacute course that is over several days and often minimal abnormality of CSF findings may delay the diagnosis, which may be suggested by MRI images showing some ring enhancing lesions after gadolinium contrast and hyperintense lesions on diffusion weighting imaging. Okay, you have a positive history, but all your cultures are negative for other known organisms, right? Even the CSF can be negative. So this comes under the aseptic meningitis reasons, right? So you do an MRI. If you find lesions in the MRI, ring enhancing lesions in the MRI, then there's more than enough a reason to tell this is Listeria meningitis. Okay, MRI is superior to CT for the diagnosis of these infections, and this is how it looks like. Okay, MRI, Listeria brain abscess, and ring enhancing lesion. Okay, can you see this? The abscess with ring enhancing lesions. This is typical of Listeria. There are other focal infections. Till now we discussed about the GI tract, where the patients can have acute gastroenteritis without bacteremia, and even the fecal culture can be negative, blood culture can be negative. If it's only acute gastroenteritis, even without antibiotics, you will be able to treat because it's a self-limiting infection. It just tells you that there is amount of Listeria in the food which is contained within the GI system itself, right? If the patient is severely toxic, you can proceed with adding antibiotics. Okay, that's about GI tract. Second, we know that if the patient's immune system is less, or if the patient has consumed too much of Listeria containing food substances, because of internalins, this particular bug from the GI tract is going to enter into the blood, gets concentrated into almost all the tissues, especially your spleen and your liver, and you know what is the pathology behind it, and you know what are the cells responsible to contract to stop the infection, and because of the bacteremia, it can go to the brain as well. Okay, so if it is spreading through the blood, your blood cultures will be positive, and blood culture is going to be the gold standard for diagnosis of this. Okay, the other form of either you diagnose a disease with your clinical picture, with your history, ruling out other infections, then you can diagnose Listeria, or by your positive blood cultures and your positive MRI findings, right? So other focal infections being eye, in the pleura, in the peritoneum, in the pericardial spaces, even the bones, joints, everything has been reported. Okay, this can form abscess almost everywhere. So now coming to pregnancy and neonate in particular. So we said you that in pregnancy, Listeria can present as just a flu-like symptoms, just like some constitutional symptoms only. But since pregnancy itself is a low immunity state, this Listeria can quickly develop into a very severe disease. The usual presentation is a non-specific acute or subacute febrile illness with some muscle pain, bone pain, back pain, headache sort of things, right? So pregnant women listeriosis are usually bacteremic. Okay, not only pregnant women, any patient in whom you have slightly less of immunity, they develop more of bacteremia. Okay, so this syndrome should prompt blood cultures, especially in the absence of another reasonable explanation. Not only in pregnancy, for any patient, if you suspect, you need to proceed with blood cultures. Involvement of CNS is rare in the absence of other risk factors on the first place. Okay, so preterm delivery is a common complication, and the diagnosis may be made only postpartum. We don't know. Okay, as many as 70 to 90% of the fetus from infected women can be infected as well. Okay, so if the mother is infected, the child can be infected up to 90%. There's a chance because of internalins. Listeria can be transferred from the mother through the placentofetal unit to the fetus, up to 90%. Okay, so very high transmission. So prepartum treatment of bacteremic woman enhances the chance of delivery of a healthy infant. It is for that reason you need to identify this is Listeria in the pregnant female. Okay, not only for the mother's benefit, for also for a good infant and to avoid this kind of preterm delivery. Okay, because of simple reason, Listeria can travel from mother to the infant. Okay, women usually do well after delivery. Maternal deaths are very rare, even when the diagnosis is made late in the pregnancy or postpartum. Overall mortality rates for fetus infected in utero is 50%. Okay, and among live-born neonates treated with antibiotics, the mortality rate can be brought down to less than 20%. Okay, a significant drop. So, in fetals, the severe infection is called as a granulomatosis infantiseptica. It's an overwhelming Listerial fetal infection with miliary, microabscession and granulomas in the skin, liver, spleen and almost in every organ system in the body. Okay, this is the severe form of Listerial infection in utero. Okay, less severe neonatal infection occurred in utero can be presented in the birth. Okay, so this patient, if the fetus occurs only a little amount of Listeria or sublethal infections, they can be diagnosed after birth as well. Okay, late onset neonatal infection typically develops around 10 days after delivery, but can occur up to a month postpartum as well. Very important timeline. Okay, Mothers of infants with late onset disease are not actually ill. Okay, so once the delivery is completed, once the pregnancy is over, the immunity power actually boosts up. So treatment. So how are you going to treat this disease? It's actually a difficult to diagnose disease. It is underdiagnosed disease as well. It occurs in a lot of groups. It targets the immunodeficiency people. It affects not only the GI tract, it can affect your blood, it can affect your brain and other organ system as well, right? If properly treated, this patients can be completely reverted or saved. Okay, this affects the pregnancy. This is one infection can be communicated to the fetus. It can cause severe infection in utero. It can cause severe infection post-delivery as well, right? So what is the treatment on it? So no clinical trials have compared antimicrobial agents for the treatment of Listeria monocytogenes. Whether this drug is better than that drug, we really don't know. Okay, so data obtained in studies conducted in vitro and in animals, as well as observational some clinical data indicate ampicillin is the drug of choice. Okay, of course you can use penicillin as well, but all the trials till date conducted have used ampicillin and it has shown good improvement. So treatment is in adults, IV ampicillin at high doses, that's 2 grams Q4th hourly. Okay, and some experts recommend double cover as well. Not only ampicillin, you can give ampicillin plus gentamicin just for synergy purpose. Okay, gentamicin for synergy is 1 to 1.7 milligram per kg Q8th hourly. Okay, remember this dosage, dear friends, it will be asked in your exam. So now, we have already informed you that HIV patients usually they will be on prophylaxis with trimethoprim and sulfamethoxazole. So this is itself a treatment. Okay, trimethoprim, sulfamethoxazole given IV is the best alternative if your patient is allergic to penicillin. Okay, usually this particular medications will be titrated as per the trimethoprim dose only. So 15 to 20 mg of trimethoprim per kg per day in divided doses every 6 to 8 hours is your initial starting dose. And this kind of dose must be reduced for patients with a renal insufficiency. Okay, and one small non-randomized study supports a combination of not only the ampicillin and gentamicin, you can give ampicillin plus trimethoprim sulfamethoxazole as well. So when we think of this particular gram-positive drug, whenever we say gram-positive, your vancomycin, erythromycin, tetracycline comes to your mind, right? So case reports document success with vancomycin, tetracycline and erythromycin, although there are also reports of clinical failure with all these 3 agents. Okay, so I don't want to try my patient on these drugs in which there is documented failures. Whereas ampicillin from gentamicin or trimethoprim sulfamethoxazole are proving good benefits, right? And other imipenem and newer quinolones are possible alternative agents that have been efficacious in animal studies, but clinical experience with these things in real-time practice is actually limited. Okay, remember, cephalosporins are not effective and should not be used, right? And neonates should receive ampicillin and gentamicin a dose based on weight. Okay, it's always a combination therapy in neonates. So now we have said you how to treat, what is the dosages and what is the drug, right? But how long to treat this kind of patients? The duration of therapy depends upon the syndrome basically. If there's a bacteremia, 2 weeks of the particular drug. If there's meningitis, 3 weeks of the particular drug. If there's an abscess or encephalitis, then 6 to 8 weeks. If there's endocarditis in both neonates and adults, it's 4 to 6 weeks of drug therapy. Early onset neonatal disease may be more severe and should be treated for more than 2 weeks. Okay, so this is the time duration. Coming to the complications and prognosis. About 50 to 70% of individuals who are promptly diagnosed and treated recover fully. Very, very important statement. Because unless you diagnose Listeria, you won't be able to treat it. Right? Unless you diagnose there is something wrong with the brain, unless you diagnose this particular thing as abscess, you won't start the patient on a particular antibiotic. Right? A misdiagnosis can even kill a patient. Right? But if all the patient has already developed some sort of meningitis or an abscess, such kind of ring enhancing lesions, permanent neurological sequelae can be seen, not only in brain abscess but also in rheumoencephalitis patients. Of 100 live born treated neonates in one series, 60% recovered fully, 1 out of every 4 died, and 13% had long-term neurologic or other complication. It is for this reason you are treating a neonate's early disease for a longer duration of time, right? More than 2 weeks. So how to prevent all these things, dear friends? So a healthy person should take standard precautions to prevent foodborne illnesses, that is fully cooking meats, wash fresh vegetables, carefully cleaning utensils, avoiding unpasteurized dairy products, and avoid keeping this kind of foods in your refrigerator for longer duration, right? Because that can grow, that can enhance the growth of this kind of listerias. Okay. In addition, this is for regular healthy people. This is standard precautions. Persons at risk for listeriosis, including the pregnant woman, should avoid this kind of foods at all, this kind of soft cheeses, and avoid eating this kind of reheat, ready-to-eat foods. Okay, this is coming as a fashion of today's world. Reheat, ready-to-eat foods, right? It's a self-explanatory term. So these are a possible sources of listeria. Okay, try to avoid all these things, dear friends. So summary, whenever you think of listeria, whenever a question is asked about listeria, first is about the history. Okay, food intake from such kind of canned, processed, refrigerated food, outside food intake, and the risk factors, whether the patient is immunosuppressed or organ transplanted or chronic illness diseases, patient is pregnant, sort of things. The risk factors has to be assessed, right? Then you need to understand about the pathogenesis, basically through the ingestion of food from the internals gets inside. If it's only localized to GI symptoms, then just correcting the dehydration, correcting the ABCD should be enough without antibiotics also, and the cultures can be completely negative. And you know how the internals help them to go inside the cell. Once inside the cell, it goes to the liver, it goes to the spleen. The first line of defense is going to be your neutrophils. Second line is going to be macrophages. Third line is CD+8 T lymphocytes. And next comes your interferons and other defense lines, right? So how to diagnose? With your history and clinical examination and diagnosis of exclusion, right? So your stool culture may be negative for all the other pathogens, common occurring pathogens, then you can suspect the febrile gastroenteritis to be because of listeria, right? So if there is immunosuppression, if there is bacteremia, your blood culture will turn positive. Okay, if there is bacteremia, it means that this particular bacteria is going through the blood to almost every organ system in your body. It can form microabscesses everywhere in the body and more likely documented in the brain, right? So your MRI can give an idea. In acute confusion early stages, the CSF can be completely negative as well, right? And even your gram stain can be misdiagnosed as pneumococcus, can be misdiagnosed as Haemophilus, right? So you need to be extremely careful in documenting the history, clinical presentation whenever you are sending a sample to your particular lab. Okay, write the full history, right? What are your suspicion, what are your differential diagnosis, and then send the sample to the lab. So they'll be focused on what they are looking at in the gram stain, right? And the treatment: ampicillin, gentamicin, trimethoprim sulfamethoxazole, and there are other trial drugs as well, right? So we have discussed about the duration of treatment, and we have discussed about how to prevent this kind of Listeria monocytogenes infections, right? So thank you, dear friends.